With those announcements made, I would like again to welcome everyone to today's webinar titled Tribal Nursing Home Stories, Improving Dementia Care. The facilitator today is Debbie Dijak. Debbie is the Facility Education Coordinator at the Archie Hendricks Senior Skilled Nursing Facility and Geriatric Nurse Leadership Academy Fellow. She is also Faculty and Advisory Board Member for the University of Arizona Geriatric Education Center. Since 2015, Debbie has been an integral leader for the Uniting Nursing Homes and Tribal Excellence Group. Our presenters today are Carly Clausen.
Hi, this is Carly.
Carly is the Director of Nursing at Morningstar Center in Fort Washakie, Wyoming. Carly has worked for the Shoshone Tribe at the Morningstar Care Center as the Director of Nursing for the last 4 years. Our second panelist is Blythe Winchester. Dr. Winchester is a full-time clinical geriatrician who works at the Cherokee Indian Hospital in Cherokee, North Carolina. She obtained her MD and MPH degrees at the University of North Carolina at Chapel Hill and completed a family medicine residency in Greenville, South Carolina. As an enrolled member of the Eastern Band of Cherokee Indians, she focuses on elder care for her own community, but also hopes to improve tribal elder health across the country as the Indian Health Service Chief Clinical Consultant and Palliative Care in Geriatrics. Dr. Winchester's recent focus has been on improving the dementia expertise of the workforce in Indian country through education. Our third and final panelist is Melissa Heflin.
Good day.
Melissa Muktoyuk Heflin is Inupiaq, born and raised in Nome, Alaska. She received her bachelor's degree in Health Services Administration with a minor in Human Services from Alaska Pacific University in 2011. Melissa has supported Alaskans for 15 years by working at the Alaska Native Tribal Health Consortium and has worked in elder outreach since 2012. She created the logo, Connecting Culture by Serving Our Elders, for the ANTHC Elder Outreach Program as her passion for serving the Alaska Native and American Indian elders. At this point, I'd like to hand it over to our facilitator, Debbie Dijak.
Good morning, good afternoon, everyone. This is Debbie Dijak. I'm from Sells, Arizona, Archie Hendricks Senior Skilled Nursing Facility. I've been the education coordinator here about 6 years. And I'd like to welcome you and thank you for taking the time to be on today's webinar. Just briefly, I'll be going over the learning objectives, which you have in front of you. We're going to talk about dementia and how it is perceived in the American Indian and Alaska Native culture. We will be exploring practices and protocols used by tribal nursing homes for residents with dementia. And we'll talk about overcoming and some of the challenges in caring for these residents. We'll also be talking about recruiting and training long-term support service staff, especially under the new CMS regulations. And some of that will involve how you assign staff and what makes sense in terms of working with dementia residents. I'd like to talk to you a little bit about the Unite Nursing Home Collaborative itself. It stands for Uniting Nursing Homes in Tribal Excellence. Unite is a collaborative that was started about 2 years ago. We worked with Alaska Native Tribal Health Consortium, Melissa Heflin, and at the time, someone named Kay Branch, who was very instrumental in beginning this. We could not have done this collaborative without the help from CMS, Indian Health Service, and Administration on Community Living. But we are about establishing best practices for tribal nursing homes, building national relationships with stakeholders, and I'll talk about that in just a minute, promoting opportunities to network. We're about evidence-based education and quality initiatives. So we want to provide culturally responsive and exceptional care for elders throughout nursing homes. Our focus areas are workforce development, education, advocacy, funding opportunities, communication, not only with each other, but with our stakeholders, and regulatory relief and ongoing communication with Centers for Medicare Service, especially the tribal technical advisory group. We partner with quality improvement organizations very actively right now with Health Service Advisory Group and Mountain Pacific, QIOs in Alaska. Also, the Administration for Community Living, IHS, CMS, our ombudsman. We have several ombudsmen in our Unite Collaborative, and the geriatric experts, including the Geriatric Workforce Enhancement Program, specifically the one at the University of Arizona in Tucson, Arizona. So now we will do a poll question. And the poll question is, what healthcare setting do you work in? And if you could be specific, as specific as possible, we want to get a feel for who our audience is. The phone may be quiet for several seconds, so don't worry about that. We'll get back on in just a minute. Okay, I'm looking at the poll results. It looks like quite a few nursing homes, about 20%. Go ahead and keep voting if you want to. We have some hospitals, about 12%, 14% home and community-based services. And it looks like some ombudsmen, which is great. Not sure who the other is, some government agencies, some clinics. So it's pretty good representation of many different healthcare settings, which is wonderful. Again, thank you for being on this call. We did have our annual meeting as part of the Administration on Community Living Long-Term Support Service Conference last November in Minneapolis, Minnesota. So we actually may have met some of you at that conference. We did a presentation at that conference. Very good. All right, I am going to go ahead and move on to a summary of some surveys that our collaborative has actually done. We surveyed our own tribal nursing homes across the country. There's approximately 18. We had 5 respond, so it may seem like a small number, but it was still helpful. So about 20% had 11 to 50 bed facilities. About 80% have 51 or more beds. 40% of our nursing homes, tribal nursing home surveys, said that 0 to 25% of their residents have dementia. 60% said that it was more like 25 to 50%. And 80% of our tribal nursing homes polled said that they do not have a specific memory care unit. About 50% of the tribal nursing homes said that they receive special funding or tribal funding for dementia care. 50% said they don't. And about 50% of our tribal nursing homes polled had specific training for their staff in understanding their tribe's culture. So I'd also like to share with you a little bit of, from that same survey, some of the best practices that came up. And again, I'm summarizing them here in general. For example, here at R.G. Hendricks, we actually do what we call behavioral huddles. So we call it our best huddles, and we call dementia behaviors, we call them behavioral expressions, and that's what the BE stands for. behavioral expressions in that the resident is just trying to express a need that they have. So we call it our behavioral expression team, and we do huddles on our dementia residents if there's something that we feel is coming up that they look uncomfortable in some way, and we need to try to address that. We use a person-centered care approach. Most of our tribal nursing homes said they try to avoid restraints and antipsychotics. There has been some usage of the virtual dementia tour in terms of community awareness, which some of you may be familiar with that. You can Google that, the virtual dementia tour. One of the nursing homes in Alaska mentioned residents that are prone to wander. But sometimes you need to adjust the environment, move furniture to give them more room to move. The sleep, the piece about sleep hygiene and allowing them to have time to sleep so they're not fatigued, which can sometimes cause other problems. Really look at the resident's past history when you're care planning, incorporating traditional foods, especially in terms of minimizing weight loss. Here at R.G. Hendricks, we actually have a snoozling room, which is a multi-sensory room, and if you'd like more information, I'd be happy to send that to you. And many of our tribal nursing homes have a full-time cultural expert on staff, so we consider those some best practices. I do want to talk a little bit about some of the challenges that we had in our tribal nursing home survey, and that was sometimes aggressive behavior with toileting, areas around toileting residents, wandering or exit-seeking weight loss came up, certain behaviors like striking out at the staff, or having our dementia residents mixed in, basically. Everyone's together on the same unit, and that can sometimes be a challenge. On the Alaska nursing home survey, this is a separate survey that was done by Mountain Pacific QIO, Lisa Johnson. I'd like to thank her for sharing this with us. They actually surveyed the nursing homes in Alaska. Now, these are not all tribal nursing homes, but they do represent many Alaskan natives. And so she had a response rate of 14 out of 18 nursing homes in Alaska. Their prevalence of dementia, they felt, was more about 75%. They felt that most do not have a memory care unit. They do use certain different types of training. Some of them use the CMS training called Hand in Hand, about 30%. Some of them use online training like Relias, which we actually use here at R.G. Hendricks. And some of their training was more homegrown, and they put it together themselves. There was training on customs and culture, but it varied widely. Some nursing homes did it once a year. Some have ongoing training. Some have no training. Some of the biggest challenges in Alaska, and I'm sure in other parts of the country, are the rural areas and not having access to behavioral health services and support, and also sometimes family visitation and participation in care can be a challenge. 9 out of those 14 that responded only received funding from reimbursement, so nothing from the tribe or from other sources. And some of their successes centered around using native foods, which our collaborative has actually talked quite a bit about, and some of the music and memory literature that's out there about using music. Some of the challenges in Alaska, and again, these are very consistent with the tribal nursing homes, had to do with staff training, individualizing activities for each of these residents, having, again, diagnosis of dementia, but many other diagnoses. And so it's sometimes difficult to provide care because there's so many different things going on at one time, and I'm sure Dr. Winchester will talk on that. And then communication and access to interpreters, depending on the primary language spoken for the residents. I wanted to mention that we do have on CMS.gov, we worked very hard on putting together a white paper, a best practice paper. It's called Tribal Nursing Homes Best Practices for Patients with Dementia and Alzheimer's Disease. It was added to the CMS.gov website in the spring of this year. It has some information, excellent resources, and you can access it very, very easily if you will go to cms.gov And then on the far right, you'll see Outreach and Education. If you click on that link, and then you will get the link that says American Indian, Alaska Native. If you click on that, and then from there, go to Long-Term Support Services link. And then you will see all the long-term support services resources, of which we are one. The Unite Collaborative is one. And you will see all of our information there. So I hope you will take a minute to find our best practice paper on this topic. I'd now like to go to the questions that we have for our panelists, and I will ask each one of them one of these questions. Actually, I'm sorry, there's a poll question next. So the poll question is, do you have experience with dementia care? And we'll just take a minute to let everyone have a chance to answer that. And if you do and you want to be a little more specific at some point in the chat box and put that in, that's fine too. It looks like we're making good progress here. It looks like quite a few of those on the call have 1 to 5 years of experience. In fact, almost 1/3 of those of you on the call, which is wonderful. About 10% have 5 to 10 years. 11% have 10 to 15 years. So over 5 years looks like about 30% also. About 30% of you on the call, it looks like it says none. So that's good. I'm glad that you're on the call. Thank you for being on the call today. All right, looks like the polling is just about done, so we'll wrap that up. Thank you. So our next question for each panelist, and I will mute out while they answer it, is what practices and protocols does your nursing home, your tribal nursing home use or have in place for your residents with dementia? And so I'm going to start with Carly Clausen. Carly?
Hi, this is Carly. One thing that's really hard for us is, I guess, just a lack of education or resources in the community. So it makes it harder for our facility and for employees. So one part of our job is also educating all of the families that come in and the community as a whole just about dementia. It's important that everyone understands what's going on with their family member and, you know, even people visiting the facility. So a huge part of our day is just education. Everyone's different, so what works for one person that has dementia, may not work for another. We also have a sensory room here, a very calming environment with soft lights and music. That seems to help people. We also have a tag-out approach. Oftentimes residents will respond differently to one staff member than they will to another. So if, things are difficult or a resident just not, responding or meshing well with one staff member, they can tag out and get someone else. So I encourage everyone to do that. We also take residents out a lot to powwows, other cultural events, and have tribal music in the facility. Drum groups come in. That all seems to help when dealing with residents that have dementia.
Thank you, Carly. I appreciate that. Dr. Winchester?
Yes, hi. So at my facility, I know that a lot of people who responded on the survey didn't have memory care units at their facilities, and we actually do. And this is an advantage in a lot of ways, and I did just want to mention why that is. And a lot of issues that come up in dementia care for our residents have to do with that transition, or even in the admission process. When do you decide if someone needs to be on the unit versus, in the general area? And we almost always have a waiting list for the memory care unit, and we do have dementia patients who are in the general area. The memory care unit is smaller, so it has less, space there. It's less overwhelming. It's less busy. There's kind of a lower staff to resident ratio, so we try to keep it more, routine back there, because, residents tend to do well when there's kind of more of a consistent routine. Obviously, it's a locked unit because one of those criteria to be on the unit is that the resident has a history of, wandering behavior. So one of those things, that we use to determine if someone needs to be back there is if they've been in the general area in the facility and they do seem to be too overwhelmed, or they're having more trouble with daily function, like they're having trouble even brushing their teeth. What we found is if we move them to that area on the unit where it is less overwhelming, they can do some of those functions before that they couldn't. So, while I know that it can't be helped in some of those areas that don't have a memory care unit, I'm very thankful, that I do have that in my facility. I do encourage you to try to seek out those, resources to try to get that, because I do feel like there are advantages for that. Other practices and protocols at my facility, I think because we have that unit, we have a, kind of admission and discharge guidelines for the unit itself, and that kind of helps to determine, in terms of having an accurate diagnosis, and then looking at the history of unmet needs and kind of problem, behaviors they may have had. And we'll usually say problem behaviors, as Debbie mentioned, the issue with kind of terms around talking about behaviors, because just saying behavior itself doesn't really describe what's going on, because we all have behavior. So I think people have different ways of, describing that. And when we're talking about memory care unit patients or dementia residents, we'll say, that they're either exhibiting, unmet needs, and you need to find out what it is that's missing, or it's a problem behavior, which means it is, affecting the resident and in some kind of way that's harming them or harming someone else. And so having some kind of policy in place, I think, that describes these other kinds of things is helpful to kind of have some terms in place, and it helps when you're training staff, because anytime you have that written language and you're going over interventions and things like that, it helps to kind of have, that information that you can refer to. I think the facility in general, we kind of emphasize, safety when you're talking about dementia care for residents. So we try to have practices and protocols in place that are identifying things to avoid crises. So one of the things we have is a behavioral monitoring sheet, and what we're trying to do is on all residents who have dementia is use this on a periodic basis to make sure that we're looking for any sources of pain they may be having. We're making sure that they're really well hydrated, and that we encourage that anywhere you can, whether it's just sherbet or whether it's having smoothies, or just making sure that they're getting hydration any way they can, popsicles, whatever it is, because that's such a frequent cause of ramping up, problem behaviors. So just having, that monitoring sheet to look for changes in routine. Has there been something in the environment different, staffing different, so that you can avoid any kind of crisis or problem behavior before it even starts. And we also have, training in place to make sure that the aides are well aware of approaches to dementia care to try to help with that. I think in general we focus on person-centered care and preparation to really make people feel, prepared and comfortable with any problem behaviors.
Thank you, Dr. Winchester. Melissa Heflin will now speak.
Hi, good morning or good day to everyone. So ANTHD doesn't specifically have a nursing facility, but we do interact with the nursing facilities around the state of Alaska. And what our program has done is shared simple language cues. So those who are experiencing dementia, they some of them revert back to their first language, which is usually not English. So we just share some simple language cues if we know them. We've had nursing facilities reach out to us and actually say, we have an elder who transitioned from the rural area. Is there a native language speaker that could come and speak to them and kind of ease them into this transition of their new living situation? We share information with our nursing homes on different Alaska-themed activities. We don't have powwows here, but we do have like our Alaska Federation of Natives, where we have native dancing. We also share information in regards to different dance groups that can practice at the different facilities. And we work with staff on providing native activities for distraction. Thank you.
Thank you, Melissa. And I'd like to mention in our best practice report that's on cms.gov, this is actually addressed, this very question, and one of our administrators in one of our Alaska tribal nursing homes says, and I quote, this is on new patients coming, new residents being admitted with dementia. They do more one-on-one time. We teach staff that for residents, it's like a puzzle that has been rearranged, that we have to help them put it back together in terms of, not recognizing, like, where's my bed, where's the TV, where's the refrigerator, where's the kitchen, those types of things. So thank you all for sharing. That was excellent. And now we'll go to our next question. How does your tribal nursing home honor culture and traditional ways? And I'll go back to Carly.
Hi, this is Carly. Incorporating culture, we are constantly inviting community members into the facility, either to stop by, have lunch, have a snack, coffee. We routinely have traditional healers visit the facility for spiritual wellness ceremonies and activities such as like cedering and smudging. We routinely invite local dance groups and singers, many from youth groups or schools, to come in and sing or dance for the residents. We just recently had a community carnival to an open house to get the community in, for something exciting. And we all the time are getting residents out into the community. We do that as often as possible. We'll just take them on a drive if they want to, go, look at animals or, just get out, go shopping, visit with friends, have coffee. We do everything we can to either get people into the facility or get the residents out into the community.
Thank you, Carly. I appreciate that. Dr. Winchester?
So just in terms of assessment and kind of, intake, when residents are coming in, it's really important for us to kind of take into consideration things like boarding school experience or military experience, because, for so many tribal people, that, has been something that has been a part of our culture, and it can definitely affect dementia care. So we do try to gather that information because sometimes you do have to get creative in terms of, management and and comfort if they've had those kinds of experiences, and it can definitely complicate the situation if there is a military history, if there's been active combat, or boarding school experience for that matter. So I did just want to mention that. And also in our facility, they do have outings, for our Elders Day that happens at our annual fair. So we do make sure they go to that. We have lots of local church groups and activities that happen for them. We have a language group that meets there each week. Of course, we have, kind of cultural artwork that's inside the facility. And then if we have residents who bring up issues to us that they feel like they're being conjured on, or that they feel like there's something present in their room, and we have someone that we can call who can come and help with their cleansing or whatever it is that needs to take place in their room. So that's an example of some of the things that we have.
Thank you, Dr. Winchester. Melissa, would you like to talk for a moment?
Sure. So we participate with one of the nursing homes. So it's non-tribal here in Anchorage. We participate with them on a monthly basis and provide a traditional food luncheon with the Native residents that are there. And we also get participation from non-Native residents. So it could be a school teacher, a pilot, or spouse of someone who worked in the rural areas. They may have become accustomed to the food, so they participate in those luncheons. We also do traditional Native tea, where we just, the concept of visiting and tea time with rye bread and Eskimo ice cream. It's something that we do on a quarterly basis as well. We also share resources, in regards to music. So one of the groups here in Anchorage is Moravian faith-based. So they have different CDs that we share with our elders, because a lot of our elders do have that religious background. So they appreciate being able to hear music that they're familiar with. And then we, allow opportunity for prayer before our food are served or before certain events. And then as far as interaction, we allow the elders to assist us as staff members in forming fry bread at one of the other facilities where, it's an actual activity, and then that encompasses a lot of dialogue that occurs between the elders and staff, and also educating. It's also an opportunity to educate our staff on, the different ingredients that are used within fry bread. So that's some of the things that we do to incorporate and honor our culture and traditional ways. Thank you.
Thank you, Melissa. And in case you're interested, that is Melissa on the left in the current picture. That's us. We also here at Archie Hendricks do some gardening with native seeds and some squash and different types of peppers and things like that. So it's another example of that. The next question I'm going to ask everyone has to do with some of their challenges and successes. We've gone over a little bit of this, but again, you'll have a chance to hear a few more stories. So I'm going to go back to Carly Clausen.
Hi, this is Carly. Let's see, and we're talking about challenges and successes. I guess
that's correct.
Okay, the biggest, challenge for us is just, it's just trial and error to find something that works. I can't say, this is going to work for everybody. This is what we're going to do across the facility, because it just doesn't work that way. We try to find something specific that works for each person, and then we just work that into their care plan. That seems to work pretty well for us. So every person could have something, totally different that works well for them. Whether we have a lady that likes to bake cookies in the afternoon. So pretty much like every other day in the afternoon, she has dementia and starts sundowning. She'll go in, make up a batch of cookies, and that just helps calm her down. That's something she liked to do when she was younger, and it helps her. So, other people, like to sit outside. We have some people that like to go for a ride. So transportation will pick them up. They'll go for a ride just out in the community, and that helps calm them down. So I guess, like I said, just trial and error, find something that works, and just get that incorporated into their care plan.
Thank you, Carly. That was good information. Dr. Winchester?
So the challenges, for caring for people with dementia are, almost too many to name, but it's also the reason why it's a lot of fun and always, intellectually stimulating and challenging to care for people. Because if you're a creative person, it's really where you can work and get a lot of benefit from this. Because in almost all people who have this brain failure and brain disease, you can know a lot about, his or her background and what, that person loved growing up, or what they cared about in their career, or what, he or she loved to do. And you can use that to find some kind of activity or something to redirect that person or to keep him or her engaged, when, they're obviously getting bored or starting to have, some kind of problem behavior. They need that kind of, stimulation. So, when you have that resident who was a lifelong boss, who was a secretary, who always liked to work with his or her hands, then all you have to do is just kind of try to find an activity, where you can use something like that, even if it's like we had to do in the facility. Someone who used to work as a secretary, and we put her to work, and we gave her papers to file, and we even wrote her fake checks, so she really felt like she had a job. And that's, that's the things that you really try to think of for people. And redirection and just really helping someone to have a purpose has been, what seems like to be the most effective thing for people with dementia. But some of the other, challenges that really seem to affect staff and facilities are the things like repetition. And so on a memory care unit, you may have a resident who is like 10-second Tom from that movie, 51st Dates, where, he may say something and then, a minute later is just saying the same thing. It can be really difficult for staff. And I just have to kind of keep emphasizing that the staff who work with that person every day are the ones who are really important in that person's life, and that it's them who are living, in that person's environment. It's not that the person is at their work. So they really just need to try hard, to provide that compassion if they can, even though it can be so frustrating for the staff and for the families, that I talk to day in and day out who are living, with people. And that's why it's so important to have that respite and respite services that you can provide, and provide those breaks, and provide the caregiver support. Hallucinations are problems for people too, hypersexual behaviors. I don't want to go over the time that I have allowed, but, there are a lot of challenges that come up, and each of them has different ways to address them. If there's time and questions about that, I can speak to that too. Thanks.
Thank you, Dr. Winchester. Melissa?
Yes, so some of the challenges that are brought to our attention is the constant want or need to go home, and home being back to their rural communities. A lot of, there are no nursing homes in our rural areas as far as like village. Another challenge is traditional food. And then the third one that I'd like to identify is working with unfamiliar staff, and ways that we have overcome these challenges are providing pictures or calendars from local Native corporations, to share with the elder if we have access to internet, sharing like a video clip on YouTube. And for traditional foods, I had made mention that we do the traditional Native food luncheon. If there's a elder that resides in an assisted living facility, we try to seek out a volunteer that can visit them, who's from their region and is available to share some of their traditional foods like dry fish. Even just simple, like piece of dry fish makes a huge difference to our elders up here. And then working with unfamiliar staff, we have the language barriers where, if the elder reverts back to their first language, and then their caregiver, where English is not their first language, we just try to find areas where we can connect the bridge in providing quality care. And some of it may just be, helping the caregiver understand the simple things, and just working with them on understanding the Alaska Native culture, because it's also new to them as caregivers. And we also share local newspapers. I don't know if I already mentioned that part, but we have different newspapers that help distribute them. And sometimes it's just connecting a native language speaker. So recently we received a referral to honor one of our Alaska Native veterans who was in the Alaska Territorial Guard, and we were able to get a Yupik translator to visit and translate in the Yupik language. Thank you for your service. Thank you for the sacrifice that you made. We appreciate you, and it was all done in the language. So, yeah, that's pretty much what I have to share as far as challenges and successes.
All right. Thank you, Melissa. I appreciate that. That was excellent. Okay, and our last question has to do with operations, specifically about not just recruiting staff, but how do you assign staff? How do you do orientation, that type of thing? And so this question will be addressed to both Carly and Dr. Winchester. I want to mention on the picture you currently see, this is some of the members of Unite. I'm actually in the center at the table. Dr. Winchester is in the far right on the table. I'm from the second from the left. And let's see, Carly, are you in here? Yes. Melissa's in the back row. 1, 2, 3, 4, 5 from the right. Well, Carly, are you 4 from the right, correct? Yeah, so Carly's in here too. So we're really... Yeah. Okay, so this is our collaborative at our annual meeting last November in Minnesota, where we were at the Administration on Community Living's Long-Term Support Service Conference. So, all right, so the last question is the best practices on staffing, and I will let Carly speak. Thank you.
Okay, like Dr. Winchester said, all of our staff need to understand that we work where these guys live, and it's not the other way around. I have any potential staff come and tour the facility, review our vision statements, and observe staff and resident interaction in a common area. I also, want to go over with them the goals for our facility, where we want to be in the future. Make sure that they understand where it is we're going and where we want to be. Let's see. We do not have an assisted living facility at this time, but it is a goal for us in the future. So that's something hopefully we can start working on too. Our facility is 45 beds. We take Medicare, Medicaid, and private pay residents. And, I just always try to interview people. I have them come out, for at least an hour and just walk around with me, which I know sounds weird, but I want to see how it is, how they're interacting with people. And I'll actually leave them, tell them to have a seat on the couch and, run and get something or answer a phone call, do something like that, just to see how they're going to interact with people, because I don't want people to work there that are uncomfortable, or, if they're like avoiding people, I'll just stop and visit with them and say, it's important that if you're going to work here, I need you to be, comfortable here and want to be involved with everybody and every resident that lives here. So.
Thank you, Carly. Dr. Winchester?
So it's really awesome to hear, Carly and like her perspective, about things. I think sometimes it's so useful, when we're, from different areas and different disciplines, just to hear, how different people, approach things. From my perspective, it's different. I'm not really in charge of like recruiting staff, per se, but I see, how things happen at my facility, and I work really closely with my John administrator, and I'll say that, one thing that you do notice when you have staff who work on your unit or with dementia residents is that, once they're there, you see who kind of just has a knack for it, and who really enjoys it, and who has that kind of gentle approach and who is more comfortable with it, who maybe even has experience with it, whether it was with a family member or whatever it is. And that really does seem to help with retention. And if you, put them with those residents where they can get to know them and they can be consistently, on that hall or in that area, then that does seem to help. And when I'm at the facility, I really do talk to the aides and I listen to them, and I am very open with them to know that they can, approach me and talk to me about any of the residents. And when I do training with them, I tell them that they are the ones that know the most about these residents and should come to me, whenever they see something different, about that person, because they're going to be the ones that notice that first. And so I think that, in terms of recruitment, they're telling them, that we have a very open communication and a very teamwork-oriented approach when it comes to taking care of our residents. And I think that also helps, too. And in terms of even volunteers or people who come in and help, what we found is we have family members who come and will bring, things for the other residents. They get to know them. And so it is a very community, centered approach, and that's really helpful.
Okay, thank you. And also, Dr. Winchester, I think I remember you telling me at one point that you actually go to the care plan meetings. Is that correct?
That's correct.
All right, thank you. That's awesome. And I just want to mention here at R.G. Hendricks, we've started something a while back with Universal Worker. I don't know if some of you are familiar with that concept, but so now we're doing with some of our dementia residents more of a one-on-one that we can actually assign someone to just be with them, to literally take blocks of time where they're just one-on-one with that resident. And I realize that may be a staffing challenge in some areas, but we've been able to do it. And sometimes it's a housekeeper or a dietary aide or an activity aide that's with them. And it's, to be honest, the people that I've seen, our dementia residents, are benefiting from that tremendously. They look calm, they look happy. I think without that, there would be a lot more, like Dr. Winchester said, some of these problem behaviors. So there's definitely some models to consider in terms of staffing. So thank you all for that information. And I just want to go over briefly some best practices in terms of training. So we'll go to that slide. I've been doing this at our facility now for about 6 years. These are some thoughts that I've put together, and then I want each of the panelists to touch briefly on some of this in terms of training staff, because it is a challenge. So some of the recommendations we'd like to make is to train everyone in the facility, not just the CNAs, not just your licensed staff. train everyone, and really take good care of your staff, because this, like Dr. Winchester said, is not easy. It is not easy to deal with some of these problem behaviors. And sometimes they take it personally, and you have to work with that and let them know that from the resident's perspective, they are not singling a staff member out. Train staff in root cause analysis. They need to ask the why questions. You need to get to why this behavior, problem behavior, or behavioral expression is occurring, and that's part of the new QAPI process. Looking at things from a systems perspective, how do we handle this as a team, not just blaming someone. How do we, get to the why? Why is this happening? Keep asking it until you get to the root cause. I've done some hands-on training here at Archie. I'm sure some of the other tribal nursing homes have too, because it's more of a dramatization of what's going on, and that sometimes will get people thinking a little more deeply about the whys. There is a good CMS curriculum. You need to always think about safety and also infection control concerns. For example, if you have a resident that's spitting, you have to think about that and how is that going to affect your infection control program, which all of us, of course, are being held accountable to CMS for. Understanding the technology that's out there to help your residents, and that was touched on a little, like music might be a good example. Offering online classes and creating curriculum specifically about dementia. Survey and evaluate your staff. Know what is their knowledge, what are their skills, what are their attitudes about dementia. Involving staff in the QAPI process, that's huge right now, quality assurance, performance improvement in nursing homes. And ongoing training and reinforcement. It has to be an ongoing process. You can't just do one class and hope everyone got it. And I will say, if you are using Relias out there, Teepa Snow, who is a very well-known expert in dementia, some of her information is on Relias, and I've been using that training, and it's excellent. Excellent. The staff has really been enjoying her videos that are on Relias. And then celebrate successes. Make sure that you're letting your staff know, wow, good job. That resident looks very comfortable. We haven't had any problem behaviors in the last 30 days. That's wonderful. And make sure we're doing that. So now I'm going to let Carly have a chance to talk about their training.
It seems it's a never-ending battle. It seems like we have training for everything, which is great, but it's hard, for me, I guess, to incorporate that into every day. I know, we try to encourage everybody to participate in any trainings that we have, but also we will have little huddles during the day, to have like 5 minutes just to do a training then with the staff on the floor. Those almost seem to work better for us than being in large groups, because we just use the current situation and turn that into an educational moment.
Okay, thank you very much. Excellent. Dr. Winchester?
So we take advantage of kind of required meetings, that aides and nurses have, and then especially when they have, required abuse and neglect training, and then I'll either provide that, and then I'll also include dementia training, at that time for the staffing. And I really like the hand over hand, and I basically gut it and take out things that I really like, and then add in other things that I want to include. And I think what's really important for staff training is role play. And though everybody hates it, once they get into it, then they really always learn a ton from it. And that hand-over-hand training has a role play exercise where one person has to be, a dementia resident who is trying to get across a need that they have, but they're having trouble communicating in some way. So you are trying to tell somebody that you want something to eat, but you can't speak and you can only make gestures, or you can only say, hey. And so it's like a very, useful exercise for them every time, that it's done. And so I really do like to do that role play with them.
I would tend to agree. It's not always something staff initially get into, but once you do it, everyone seems to enjoy it. So, Melissa, we'll let you finish.
So I just highly recommend that folks reach out to their local Alzheimer's resource agency. We do have one here in Alaska. Also, if you do have an Aging and Disability Resource Center, and then also reach out to your tribal organizations to see if they have different culturally responsive training opportunities that someone from their organization can come and share with your staff. Yeah.
Thank you. So that's excellent. And I think, Adam, we're ready for any questions.
Great. Right now, it's a good time to enter your question in the Q&A box. We've got a couple of questions already. One is how to discern or identify actual dementia versus other potential factors that may mimic symptoms.
Okay, Dr. Winchester.
So I'm assuming they're asking mimicking symptoms of dementia, and the key thing here is, what usually pops up is dementia versus delirium. Dementia is something that develops, typically over months to years. It's not something that's, happens quickly. If you have, something like delirium, which people who have dementia can develop, it's typically because, they develop something like an infection or something that's triggering that. The difference with delirium is that their attention, waxes and wanes. So one minute they'll be able to focus on something, and the next, they can't. They may be even having, hallucinations, or typically they're picking at something in the air. So it typically is, quite severe and acute. It happens really quickly, and there's a reversible cause that you need to be looking for. The difference with dementia is that it's happening, slowly over time. If it's something that's happening quickly, then you're looking for delirium, you're looking for, thyroid problems. Is it an underlying depression? Is it an infection, dehydration? Do you need to get some kind of head imaging to look for a tumor? There are lots of reversible causes, but the main thing to distinguish is that dementia is a slowly developing process. And I think people don't realize that because there is still this kind of lag in awareness, of the process and diagnosis of it.
Great. Thank you.
Our second question, what kinds of activities do you involve your elders in memory care units?
I don't know, Dr. Winchester, if you want to take that one, or Carly, I'm not sure.
I can answer this real quick. So we have a really awesome activities coordinator. She has this assessment she does to determine the level of activities she can do with people. It's some kind of assessment tool. I'm sorry, I don't know what it is. So that way she knows, can they color? Is that too advanced? Can they just work with an edible clay? Can they put something together? So she uses that, and then based on, the levels of the different residents, she decides which activities she can do. But that's an example, working with edible clay, or coloring, or doing some kind of craft, with glue, if they are able to do that. The residents that we have are very, on most side, low functioning, so they can't do very advanced crafts.
Okay, Carly, did you want to hit on that or talk on that briefly?
We just, evaluate each resident and see, where they're at. Like Dr. Winchester said, what things are they able to do, and more, relevant than that is what do they like to do. If they like to, just do one thing or the other, then we try to do that, or build a program or a plan of care that's centered around that, what it is they like to do.
All right. Thank you, Carly. Adam?
Yes, great. Thank you, everyone. So we're nearing our time, and we have some other questions, but we can answer those, and we'll send out a post-webinar kind of e-blast, and we'll address any of your questions we didn't get to today. So in conclusion, I again want to thank Debbie, I want to thank Blythe, Carly, and Melissa for your time and sharing information about tribal nursing homes and improving dementia care. And just in closing, I would like to remind everyone that today's webinar was recorded and that the audio and PowerPoint will be made available online at cms.gov. Thank you again for joining. Yes.
Adam, I wanted to say, too, you're welcome to give out my email, too, for people to ask questions. I'll make sure they get an answer.
Oh, perfect. So we'll provide everyone's email address, so please feel free to reach out to Debbie or any of the presenters with any of your questions and follow-up. All right, well, now that we have concluded our webinar, our session has now been concluded. Again, thank you, everyone, for joining.